Welcome, everyone. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. Thank you for joining us for our third in a four-part series, Advancing Inclusion and Belonging in Health Sciences Education. Today's session is Advancing Health Equity by Drs. Claudia Chambers and Maureen Tierney. Just a few housekeeping items before I introduce our speakers. This session is being recorded and you will have access to the recording and slide presentation for future reference. We invite you to ask live questions or submit them in the chat. We'll get to as many as we can by the end of the session. We do ask that you remain muted with video off unless asking a live question, just to assist with our recording. Also, this session is eligible for CE credit and you'll receive the website and activity code before we conclude. There is a short survey associated with the continuing education, and we thank you in advance for providing feedback as we continue to provide you diverse and robust programming here at Creighton. Dr. Claudia Chambers is the new Associate Dean for Medical Education in Creighton School of Medicine and based on the Phoenix campus. She is also an Associate Professor of Obstetrics and Gynecology with Dignity Health Medical Group and an Assistant Clinical Professor with the University of Arizona. Dr. Maureen Tierney is both the Chair and Associate Dean for Clinical Research and Public Health, also in Creighton School of Medicine, and is based on the Omaha campus. She is also the Medical Director for Clinical Research with CHI Health, and we appreciate both of them sharing their time and their talents with us today as they talk about advancing health equity. So Dr. Chambers, if you're ready, I'll turn the time to you.
All right, thank you very much. So as we kind of discussed today, we're really going to talk about a 30,000-foot view around the School of Medicine health equity strategy as it pertains to advancing inclusion and equity in the School of Medicine here at Creighton. This really is an evolving process as we build out our strategy, but wanted to share with you some of the tenets of our strategy at present. The objectives today really are to share at a much higher level, kind of, like I said, a 30,000-foot view of our strategy around health equity and the impact we want to have in the communities that we serve. We'll discuss the pillars of approaching this, as well as discuss the impact and value of research, which is where we're really going to sit today, is the focus on population health research and how that is going to be critical to our advancement in health equity and inclusion efforts. Think about health equity and the value of health equity and advancing inclusion. What we understand is that in our communities today, that the lack of health equity is affecting the clinical realm in a significant way. Our patients are getting less quality care, especially those who are underserved. And it's really important as we think about our health equity strategy for the School of Medicine at Creighton, that we're thinking about how do we use our tools to bring equity to the bedside. It's through a concerted, intentional effort. It really is, it's a multi-pronged approach. It's a complex issue. I like to tell people it's, when I was asked to build this strategy, it was as if I was being asked to boil the ocean. And I think the reality is that we can't affect change without really being strategic about how we're going to approach this. As a university and a School of Medicine, with the resources and assets that we have, how do we partner with our health systems in order to actually impact change? And then really the other purpose behind the strategy is to provide the highest level of care through elimination of obstacles. Robert Wood Johnson said that health equity is about overcoming those obstacles. And how do we do that to provide the best care for our patients and those who are most at risk? We'll talk a little about developing structures and processes to support and support that ultimate end. And then talk about how we partner with our physician enterprises and health systems in order to leverage those assets that we have between the two entities to accomplish that as well. When we think about where we can have impact in healthcare, especially in the School of Medicine, we think about those areas where we actually have resources. We have relationships with the community. We have a school of law where we can learn about policies, regulation. We can be involved in advocacy. We also have obviously this unique relationship with health systems where we can affect policy and the environment of care. And then there's also the opportunities to affect education and the workforce. And at the end of the day, that's where we really get to the point where we can be on the sharp end where we're touching the bedside and really transforming healthcare. The key components or pillars to the strategy really are focused around education and training, our workforce development, advocacy, as I mentioned before, and then collaboration and community engagement. Research is central to that. And again, the bulk of this presentation will be conversations around how we impact the community through research and population health, as well as really this concept of precision health, where we're really focusing those energies and research around those communities most in need. And then looking at health solutions and translational research and the impact that it will have on changing healthcare. With regards to education, some of the work that's already been done is surveys around the campus, looking at the common definition of what health equity means and how we impact it. There have been surveys both at the level of the institution at Creighton, as well as on the GME side, where we're really looking at what does that mean for us as healthcare providers. And then developing educational curriculum to address those social, racial, gender needs to make sure that we're addressing the needs of our patients who are most at risk. Part of our strategy is to look at creating a playbook, not just for documentation, but for communication. So often, part of the reason that we're not successful at having impact is we're not all speaking the same language. So as part of our work in the School of Medicine is really starting to develop that curriculum around these options to help us speak the same language in those spaces, as well as bias training. When it comes to bias training as part of the educational experience, it needs to happen. It needs to happen often, and it needs to be repetitive. And that's part of the strategy, is to continue to build that into the learning experience, not just for our students, but across the continuum of learning. It's hard to talk about School of Medicine in exclusion of our graduate medical education and our residencies. Really, it's important to think of this as, again, a continuum of learning and education that's going to impact the bedside. This is where we impact the environment of care as well, because all of our learners are learning together. There are opportunities that we're exploring in Journal Club, opportunities to consider really health equity as part and parcel of our Journal Club experience. And some conversations that we've had at the GME level of even including, once a month journal clubs specifically geared towards health equity, or including that health equity questions as part of our journal club experience at every journal club. Book clubs, obviously at the university level, as well at the level of School of Medicine, we've had a number of different offerings for book clubs and informational gatherings such as these, where people are able to discuss their ideas and concerns around health equity, as well as our impact in the School of Medicine on the bedside, again, for those patients who are struggling or who need additional care. And then M&M, this is again another opportunity for us. M&Ms, we've discussed at the GME level, looking at disparities in health and making that a lens by which we look at every M&M. It's not just about the care we provide, but where we've fallen down and where those mistakes have happened as a result of biases or our approach to the care of the patient. Being intentional about making that part of our M&M experience is part of our strategy as well. And then finally, looking at committees that involve our students as well as our faculty and our residents in order to help with providing resources for those within the system who may be experiencing biases or having difficult seasons, but also mentoring those individuals through that experience so they feel supported and want to stay within the system and support that experience for others. And then finally, as we talk about education and the horizontal educational experience, creating shared resources along the continuum of learning to include our faculty, so that there are individuals who are champions within the system who help to build a cadre of resources as well as support for those in the system and outside of the system. The cultural navigator is a concept that we are developing, which would allow for individuals to have well-defined roles as cultural navigators, whether they're student, resident, or faculty, where they can help with cultural humility training. They can be a resource to others in the system, and they can train the trainers. As we think about educational experience, really part of what we do in the School of Medicine is develop workers for the workforce. And so as we transition from the educational experience, really we think about how are we building the pipeline for those providers who are going to change healthcare in the long run. And part of that is about representation. We know that pipelines and building a pathway programs is really critical to being able to provide providers who actually reflect the communities that they serve. And so pathway programs are quintessential to that discussion. As a result, we've worked on in both pathway programs, which some examples of which Dr. Ron Johnson, and our DEIB, our associate dean in that area, has also worked on some mini medical schools and things of the like. And we are continuing to build out programming to help support young people who are interested in entering medicine and the health system and healthcare as well. In admissions, we've looked very closely at how we are approaching admissions. We've made bias training an annual part of our experience. Again, that idea of being ongoing and repetitive so that those who are part of the selection criteria, our selection process for new students to the medical school, understand how their biases may impact the selection process. As well, we look at and have looked at formal training around the holistic review of applications so that we can make sure we're seeking out the right type of individual who's really going to have a lived experience such that they can reflect the communities that they serve, but also that we're putting value on more than just grades and numbers, but on the distance traveled, which really adds value. Additionally, we've worked on some things like admissions committee and how we review those applicants to make sure that we're thinking about more intentionally who we're bringing into the healthcare system. Again, making it clear that we want to bring in individuals who are adding value at multiple levels, not just academically sound, which we are already getting that, but those who actually can bring unique experiences to the bedside, whether it be that they're multilingual or they actually have come through or lived the experiences that many of our patients have so that they can connect on that level. Finally, we're partnering with our health systems to build out leadership development, as well as thinking about more intentionally around succession planning so that we have those who are of diverse background within the system, that we are giving them resources and then teaching them how to be successful within the system, working very intentionally around community building, as well as creating resources and conferences for individuals to attend so that they can also learn how to be part of that process and experience, really building leaders for the future who can then affect change. And then as far as environment of care, creating mechanisms at the level of the hospital system for people to report experiences where we could improve diversity and inclusion, and that we are being responsive to those concerns. Scholarship, I think that's really critical as we talk about workforce development. We know at the level of even admissions to medical school that the greatest hurdle to overcome for many of our first-gen and underrepresented students is finance. And so really looking at gearing our scholarship funds such that we're giving individuals resources to overcome that hurdle. And then finally, recruitment. Again, being very intentional about how we recruit, using our cultural navigators as an aid to recruitment as part of that strategy, and then thinking about even at the GME level, how do we engage individuals who are going to bring a richness to the experience for the patient. Advocacy obviously is a critical part of our strategy as we think about policies and things of the like. This one, again, is in process as we build out formal advocacy education and training, both at the UME, GME, and faculty level. I think for a lot of people, they want to advocate in these spaces and areas, but need tools to be able to do so. And so part of the strategy for the School of Medicine is really to start to create opportunities to have formal training in this area. As well as training in governmental financing and understanding the power of the levers that we can pull when we know how to navigate those areas. And then creating spaces to discuss these challenges. So town halls and interest groups are critical to this discussion as well. And you'll see as we talk a little bit more about, even in the research area, creating these affinity groups around both research and advocacy, I think is critical to moving the agenda forward. And then community partnerships. There are a number of community partnerships throughout our health system. We're really looking to be very intentional about who we partner with. Obviously, we won't be able to affect every community, but we can affect those communities that we already have strong relationships with. So examples are some of the relationships that we have in Omaha, which I know Maureen is going to talk a little bit more about. Here in Phoenix, where I reside, we have a very strong relationship with St. Vincent de Paul. That's a relationship that we've developed over time and continue to work with. We also have a relationship with our refugee population, really working on focus groups with our community partners to make sure that we're not just delivering, but delivering on their needs. And then finally, we'll talk about, how research is critical to this. We really can't impact what we don't understand. And so as we think about research is the light or the lens by which we look at how we're actually impacting the communities that we're serving. There's been some discussion around an annual symposium specifically geared towards research that is in that health equity realm. And then looking at where there are needs in the system for additional resources so that we can do the research that will be impactful for these communities. We have already started a research interest group, which is focused on health equity. I know Dr. Scott Shipman and Maureen Tierney have been really critical to moving that agenda forward. This is going to be an opportunity again for those affinity groups to come together and look at research across campuses, outside of this campus, maybe even some global research as we think about our global health scholars. But again, this opportunity to leverage all of our different assets among the different colleges, as well as outside of the School of Medicine, to be able to develop meaningful research in this area. And then obviously IPE research, interprofessional discussions around how do we truly affect healthcare models and what we do within the healthcare realm. Sorry, I'm losing my voice, so I'm trying to keep it going for the last little bit here. And then we'll talk about how research is part and parcel of developing those clinical scientists of color who can reach out to the communities and really have an impact. I think it's impossible to reach communities where there may be a lack of trust for historical reasons and the like, without having clinicians and clinical scientists who represent their communities. And that's part and parcel of what we do, both with our MD, PhD program, and again, with that selection process and our global health programs, where we're developing individuals who are coming from these communities, but giving them the skill sets to be effective leaders in this space. And then tracking and trending, data sharing, and being able to affect change in these areas is really critical to that strategy as well. And again, I'll defer to Dr. Tierney to talk more about what that looks like real time. And then the question about partnerships with industry. At the end of the day, industry can be a very powerful ally. It's what does that look like for us as we go forward? And I think that's something that's still in question as we think about moving forward in this space. Moving health equity strategies forward, like things with regards to telehealth and some of the devices that are available out there. Where does that play a role in our experience? That's really part of some of the conversation that's still being developed around health equity. Finally, clinical delivery models. As part of the research realm is really thinking about how we provide care in a way that actually is not just meaningful, but also understanding the different needs of the different communities that we serve. Standardization of care such that we're avoiding those biases in the care that we provide, looking at quality outcomes, involving approaches that actually take into consideration that our patients in certain populations, in these underserved populations, may be exposed to more trauma, that we maybe need to approach this differently than we have for other communities. And then looking at prevention programs that actually work for each community. Again, some of that partnership with the community is going to be critical so that we're actually figuring out how to meet the needs of a community with the community right at our side, telling us what works and what doesn't. And then making sure that we're looking very clearly at access, which can be the primary issue for many of our communities in need.
Moving on, talking about advancing health equity, in particular as it relates to research. And so I have no conflicts of interest, and the objectives that I have for this next 20 to 25 minutes is to demonstrate the three ways health inequities, and research are intersected by addressing and looking at healthcare inequities directly, ensuring an equitable inclusion of historically underrepresented groups in research populations, and diversifying the research workforce. And then showing how we can achieve some of the above, which is utilizing data on community needs, establishing trust involving the community in the development of research questions, and then creating the research workforce diversity, especially through hiring culturally competent researchers and community advocates. So what I am going to focus on primarily today is the studying of health inequities, particularly social determinants of health, and ways in which overall, but in particular ways in which Creighton is doing that right now, and then how we want to continue to grow that effort. So when you're studying health inequities, you can do it from a very traditional approach as to how much inequity is there, what is the source of that inequity. So in particular, and as Claudia mentioned, one of our goals is that almost every time, if not every time, our goal every time a new research proposal is brought up in any of our research interest groups. So not just the healthcare disparities research interest group, the question is asked, can we look at this through a health equity lens? So that's being added to projects in terms of benefits of certain procedures, et cetera. Are there differences based on race, ethnicity, financial status, and other social determinants of health? But in order to look at how to reduce the inequities and improve social determinants of health, those kinds of studies and that data is actually not nearly as available as we'd like. And that's one of the things we're trying to do with some of our efforts here, along with certain other colleagues around the country. And one of the best ways to do that is with community-based participatory research. So when asking the questions about health disparities existing, as many of us know, or some of you in the audience aren't necessarily old enough to realize this, but 20 to 30 years ago, limited data was available in almost any study, because there was this desire to have a homogeneous population. And so everybody was a white male in your study population. In 1993, the NIH mandated on the inclusion of minorities and women in research data. So it's really only within the past 20 years, and really, I would say really more within the past 10, that the populations looking at the efficacy of certain therapies have been more broadly representative of the population at large. So I think we all know that there is clear-cut evidence of disparities in certain areas. I just wanted to call, certain things in particular. If you look at, there's a number of studies looking at breast cancer and race and ethnicity, and clearly there's an overall increase in mortality in Black women as a result of breast cancer. But there's been certain studies that have tried to look at, if you match for age at diagnosis, if you match on socioeconomic status, that change diminishes, which clearly shows that it's primarily, in this particular scenario, a lack of access, because Black women are at a later stage at diagnosis. less likely to get hormonal therapy. And so it was one study that actually showed in particular how SDOH affected efficacy of care. COVID-19, we all talk about how there was a significant mortality difference nationwide. If you look at African Americans and Native Americans, that the mortality rate is at least twice in whites. For Native Americans, it's even higher than that in comparison to whites. But, you know, one of the interesting studies, again, which sort of supports a little bit about access, both myself and Dr. Ann O'Keefe were very involved in the effort, Dr. Vivekanandan and all the ID and pulmonary docs. But in public health, we actually found that those mortality differences, that degree of mortality difference, it was markedly less in Omaha to really about 1.2 times. Still, you know, any difference is too high. But the difference here is, particularly in the earlier part of the pandemic, everybody went to the same hospitals, no matter what neighborhood they actually lived in. And so individuals, and Grand Island was actually became expert first in the care of critically ill patients. But there wasn't a differentiation as to where people got their intense care based on race and ethnicity and financial status in Omaha. And as a result of that, the mortality difference. So I just wanted to point out, again, issues that support how access is actually key. If you're looking for data on the magnitude of healthcare disparities in preventive care and in the treatment of chronic diseases, one of the best places to find that data is the annual MGH report on equity and healthcare quality. It's put out by their Disparities Solution Center, which is a combined MGH Brigham program. And it clearly shows that there are significantly lower rates for breast cancer, cervical cancer, and colorectal cancer screening for patients of color, and lower rates of breast and colorectal cancer screening for patients who have limited English proficiency. There's lower rates for patients with Medicaid, lower rates of depression screening for patients of color, patients with limited English proficiency, as well as Medicaid patients, lower rates of tobacco screening in these similar populations, disparities in outcomes with diabetes and diabetes screening. So not only do we see, you know, differences in outcomes, we see differences in screenings, which, as we all know, the earlier you intervene, the more effective therapy is going to be. So I think, you know, what are the social determinants of health? So race, ethnicity, English language proficiency, health insurance, financial well-being are clearly things that affect outcomes and the kind of care that individuals get. Some other more structural issues are access to care, food insecurity, housing insecurity and homelessness, financial stress, and transportation. So distance actually from care. Now, you would think that by this time, there would be a lot of data on the efficacy of eliminating social determinants of health, but there actually isn't. There's, again, a lot of data, and it's always a good place to start to see where are the inequities, because you need to figure that out before you can determine if you reduce these barriers to care that you'll actually see improvement. But as Claudia mentioned, we actually need to show that. And one of the primary reasons we need to show that is if we can show that certain interventions clearly lead to better health outcomes, and in particular, more cost-effective care. Insurance companies, Center for Medicare and Medicaid are more likely to cover those interventions. So I'd like to point out two programs that Creighton has actually spearheaded that are very unique and are actually starting to show those benefits. So many of you may already know about the Creighton Financial Health Collaborative and Financial Success Program, which to me is actually brilliant in its simplicity. but it was a randomized control. It's an ongoing program, but they did a randomized control trial evaluating the impact of their financial success program on the both financial well-being and health of single mothers of low income. And they had 345 participants over a little bit more than 3 years, used an intent to treat analysis. And these were financially disadvantaged individuals at 200% or less so they were single moms, primarily in North Omaha, and their family income was less than 200% the poverty level. And it was really undertaken with the understanding that persistent financial stress leads to chronic disease from a number of studies. And I will provide these references when Dr. Seaman shares the slide about triggering inflammatory and immune dysregulating cascades that promote chronic disease, reducing the uptake of healthy lifestyle behaviors, what we call the bandwidth tax. So, there's only so much stress in life that can be managed before you're not able to actually follow certain healthy behaviors. And so what was done with these, or what was provided, it was a randomized control trial, and it was provided both group and one-on-one financial coaching over I think the more intense part was over 9 months, but continued follow-up beyond a year. And as a result of that, they showed significant reduction in financial strain. So this is the intervention group, and this is the control group. So there's significant reduction in financial strain. Next slide. But some of the more, there's some other financial characterizations here, but one of the most important thing is that if you look at certain health behaviors, so the intervention group dropped their rate of smoking by 5%, whereas the control group, it actually went up over this period of time. That was statistically significant. The lack of avoidance or the reduction in the avoidance of medical care due to the cost of that care was also significant. So if, more than 15% drop in the intervention arm, because these individuals were coached not only on just managing finances, but how to improve finances, how to approach job opportunities, how to get coaching for those job opportunities, job quality improved, and therefore salary improved. There were an increase in bills being paid on time, reduction in late fees, less overdrafts. And one of this is, one of the reasons I love to share this is that, they came out, this group led by Julie Kalkowski, Maggie Kalkowski is involved, Nicole White, and Kevin Fuji, Katie Packard. But coming up with these particular outcomes showed significant behavioral change. And that is really crucial because very few studies have actually shown that. And there was actually a KETV story on this, which gives you a lot more specifics about this and shows interviews with these patients. So that's just one area. Again, there aren't a lot of examples countrywide where somebody has actually shown that by affecting a social determinant of health, you actually have improvement in health outcomes. The Bay Area Regional Health Inequities Initiative, and this is, there are a number of sort of really nice infographics that look at the intersection of social inequities, institutional inequities, living conditions. And so it's looking at things from an upstream basis. So from a social determinants of health basis, as opposed to the way we've traditionally looked at, which is risk behaviors, disease and injury and mortality as downstream. And so the goal in STOH research is really to try and move things to the left on that diagram. So I want to tell you a little bit about the Creighton Community Collaborative. Some of you already know a little bit about this. I'm actually going to skip over a number of slides to make sure that we actually have time for questions. But this was a collaborative that came about because during the pandemic, particularly the early parts, a lot of people weren't registering with Medicaid, weren't leaving their houses. And so Medicaid MCOs in the state of Nebraska and most other states can only keep a certain amount of profit. And once you get beyond that 2% profit, that money needs to be reinvested in the community. And the CEO at United Healthcare wanted to look at both ways to, actually providing money to reduce certain gaps in SDOH, but find a way to actually show the benefit. And they felt that because of Creighton's 7 schools and all its levels of expertise, some of the research we've done in clinical research and public health, and our mission, that we would be good stewards of this funding. And so United Healthcare provided $3.9 million last year and is providing $1.5 this year. And now an additional Medicaid MCO, Nebraska Total Care, is providing additional $1.5 million. And the goal was to look at housing support, food insecurities, access to primary care, COVID-19 vaccine confidence, and also workplace development to try and improve certain social determinants of health and measure the benefits of those interventions. So there's a leadership team, that's myself, Andy Camera, and April Dixon. But more importantly, there's an executive steering committee that includes at least one representative from every school at Creighton. And I think this is one of the reasons it's such a strong program. And these are the individuals from all our schools. There are over 15 community-based organizations that are actually supported by these funds, and 4 Creighton programs that are actually supported by these funds. And they do things like providing food to individuals experiencing food insecurity, improving access to care, improving housing support, trying to prevent housing loss. This is a wonderful program that actually involves psychiatry residents at Creighton being embedded over at Omaha Housing Authority to try and help people with mental health needs to prevent eviction. There's law school programs to try and reduce eviction, supporting and expanding school-based dental screenings. RISE is a program that supports individuals released from incarceration. So there's just a lot of wonderful programs that are involved. One program is, another one is Nebraska Family Works, which is actually an addiction recovery plan that's had tremendous success. And so the funds may actually go to support a particular program within a CBO or within Creighton, or just provide funds to assist in their overall management. So in this program, for example, we end up providing somewhere between 10 to 15% of their overall total budget for a year. And this program has had tremendous success in clients leaving the program drug-free and in involving their families in their recovery effort. The dental school, Healthy Smiles, is so probably 75% of this program now is actually supported by the funds from the Creighton Community Collaborative. And so you're actually going into schools in low-income areas, or Ashley Aubrey and her team, and finding children and screening children, and in particular, children who are refugees have actually, and immigrants have actually benefited, I would think, particularly by this program because they have no dental coverage at all. And they were able to expand it with this funding. So if you have children who have severe urgent needs, so they found 32 children with urgent needs, and meaning teeth needing to be pulled, abscesses, etc., that they found 37 adults from children's families who are also now getting dental care. The CURE program, which is a program that involves the financial program I talked about before, a food pharmacy, health and wellness coaching, and social work services, that in this program, they've actually shown, and this is close to between 80 and 90, I believe, enrollees over the year. They were able to ascertain A1Cs for about a quarter at the 6-month mark. And there was a reduction, relatively small, that's a short period of time. But of the people who were actually able to drop their A1C below about 7, about 40 to 45% of the subgroup that information was available dropped their A1C. So I'm going to skip over this slide because I think I've sort of talked a little bit about what this community collaborative has done. But the other thing I just also want to point out is that the steering committee also includes some major community members. So Chris Rogers, who is the chair of the Douglas County Health Board, Dr. Leah Casanave, who is the head of community services for Douglas County, both sit on our executive steering committee. We plan to try and increase the number of community folks involved, because I think we've done a very good job of finding programs that will benefit for the funding and will actually work. The other key thing that we're doing, as Claudia referred to, is we have to be able to measure. So we're providing this support for these wonderful programs, but how are we going to measure their outcome? And that's actually one of the major places Dr. Ann O'Keefe comes in. We recruited her from Douglas County Department of Health a year ago, and she is extraordinarily talented in this kind of outcomes analysis. And so this is one of the things we're doing with these programs. We've now sort of started to streamline that they're reporting on a monthly basis, outcomes that are unique to their particular program that can then be followed over time. We're also evaluating the process itself in order to show what works and what doesn't, particularly as it relates to what referral patterns work and what they don't. Clarifying the data sources, because as Claudia indicated, data in terms of healthcare services and healthcare outcomes in this kind of work is still a complicated area. And trying to pursue a little bit more an accountable care organization model. So, back in 2016, there was this very excellent editorial or perspective article on accountable healthcare communities. And it was not long after that actually CMS actually announced that they were going to move to an accountable care organization model. And these next two slides were put together by Dr. O'Keefe, which talked about kind of what we're trying to do. The current system, which is where the burden is on healthcare, and not enough burden on trying to focus on preventing the need for healthcare, and more of a burden on social determinants of health, which will reduce healthcare costs, to a model where we're talking about an accountable health community. And this is where having Scott Shipman now at Creighton involved in implementation science, that public health and population health on both campuses working together to try and support this kind of model is, I think, going to be an extraordinary future over the next 1 to 2 years. So in summary, how are we going to improve Creighton's efforts to reduce healthcare disparities? As I said, public health and population health are going to work closely together to focus on implementation science, to expand data access and analytic capacity. We're going to work across campuses to support work in groups already in place and expand to others. The research interest groups on health disparities, and focusing within research interest groups for particular subspecialties on looking at things through a health and equity lens, or health equity lens would be a more appropriate way. We want to expand expertise in social behavioral regulatory approaches, look for new ways to fund this work, but one of the things that we need to do is try and convincing people to fund this work. We have to have the data to show that the work is successful. And I think it's really crucial to expand diversity in the research workforce. For example, our group, the CCC, just heard a report of a group looking at community needs and sort of a high level view, but they only did it in North Omaha with English and Spanish, and completely didn't include the Karen speaking community. And so, you know, and I'm going to call out Amy McGahey, and there's so many people who've done work in this area, Amy and Deanna, Boston. But Amy has told me how their interpreters have actually, several interpreters, or I don't know if it's several, but at least two, have actually now entered the healthcare field and are now working, you know, in that setting. And I think that's extraordinary. Just a few other things that I just like to mention that I haven't included here is one other area. A lot of the work for the Creighton Community Collaborative is based up at the Highlander, and is therefore supported by Dr. LaShawn Johnson. And I think that's really an extraordinary benefit to actually have that work done within the community. Claudia already called out St. Vincent de Paul, actually or supported St. Vincent de Paul in Phoenix. But I think these particular kinds of places to support this work, and then continuing the work with a very interdisciplinary, interprofessional approach, is the direction we need to go. So thanks so much for your time. When these slides are shared, there's going to be a number of references and then some few additional slides that we couldn't get to. But with that, I'd like to stop and would love to hear either other work individuals are doing, points they'd like to make, or questions they have for either Claudia or myself.
Oh, Maureen, this is Marvin Bittner. Can you hear me?
I sure can.
We published a very short article about some disparities in vaccination status. And the odd thing was, this was just looking at people who were actually seen by primary care at the VA. So in theory, there was not much of an explanation for access as a barrier or finance as a barrier, at least directly. And it was very odd that in this setting, we still saw lower uptake of shingles vaccine among people who were classified as Black compared to white. And then when we looked at the same group of primary care folks in Omaha, we saw no difference in uptake of COVID vaccine. And it really raises a lot of question what was going on, whether there was special efforts in North Omaha to get out the word about COVID vaccine, if it's just information, trust, what have you. We're sort of interested in exploring this further, but you pointed out that a lot of the work you've been doing is very innovative. And one of the challenges we have is, dealing with the VA Research Service, because this is not the kind of rat work or multi-center grant work they're used to. And I'm wondering if you have any tips on how we might have some impact on the function of the research service, because it's something of swimming uphill. It's an uphill climb to convince them that this really is a legit subject for research. And I just wonder if you have any thoughts on this, or any thoughts on what we think is a paradox, why there would be the disparity in shingles vaccine in this population, but nothing like that for COVID.
Well, I want to, in particular, make mention of Dr. Sade Kosoko-Lasaki's work with community health advocates in North Omaha, where there was a very extensive education effort about COVID vaccine, working with a lot of community-based organizations, a lot of churches, to actually improve COVID vaccine confidence in North and South Omaha. So I do think that that's maybe one of the reasons why that gap was reduced. In terms of Shingrix itself, shingles vaccine, that would be interesting to look at. It's a vaccine with more side effects and significant costs. So I wonder if that, but would love to, talk to you more about that. In terms of the VA, although the VA's probably been doing this better, but JCHO has now required that race, ethnicity, language proficiency, et cetera, be recorded upon admission for all patients or all new patients. And so that data being available. But one thought, maybe we can talk offline, Marv, is whether or not some of this conversation can actually happen at the VA, like bring this talk over there.
Yeah, I think that might be a great idea. Because as you point out, the VA has systematically recorded race, ethnicity. There's a very rich electronic health record that's designed primarily for clinical use rather than for billing. But again, getting people some awareness of the potential to do a huge amount of good, have a tremendous impact as with this kind of study, as opposed to what they traditionally do with rats or large multi-center trials of human things. This is a new dimension for them. And I think it would be good to have some conversations offline. Yeah.
Thanks, Marv. Anybody else? There's got to be some burning questions there.
Dr. Tierney, I did not have any burning questions. I just want to say thank you to both of the speakers for such a phenomenal job discussing such a big topic. There was one thing I think I wanted to put a quick plug in while we're discussing health disparities. This has been a big conversation in the ID division recently. We are starting to see more HIV diagnoses, new diagnoses, and late presentation of young people with AIDS coming to the hospital, at least here in Omaha, Nebraska. I just wanted to put in a quick plug because the patients that we're seeing are not white. They are predominantly Black or Spanish speaking. And so I think moving to make sure that we do a good job of doing our screening for adults when we have that opportunity might be a way to significantly impact some of those particular disparities. And a lot of times they're coming in with partners who are either testing positive or have not yet been tested. So I think it's probably a big issue that I think it's worth keeping in mind when you're just seeing routine patients in the clinic. Is this someone that might benefit from screening so we can address it while they're there? But thank you again so much. I love this lecture series. It's always so great.
Kelsey, it might, let's talk. I actually, Dr. Kosoko-Lasaki's received a very large grant in terms of supporting community health advocates in North Omaha. Now that's going to expand beyond just vaccination. And I'm wondering if this is something where I know that you're actually helping in some education with Dr. O'Keefe for that group of health advocates. So I think that might be a particular group that could help get that message out to the community.
We're at the top of the hour, so.
Thank you so much, Dr. Tierney and Dr. Chambers, for sharing all the wonderful programs that are happening at Creighton. It's so nice for people to hear about the things that are going on or that they could get involved in. We had several things in the chat saying thank you so much for all the information. And we love that there is such an interprofessional collaboration that is going on. Somebody from all the different health science colleges, schools. So that is a great plus for all the things that are happening at Creighton. So thank you so much for sharing your time.
Thank you so much. I think Dr. Townley might have a quick question, if that's okay. Dr. Townley, go for it.
I guess I just want to say that, at the Global Health Conference Midwest, which also had a pathway for Native American studies as well, just had some really excellent speakers who talked about the role of historical trauma, and I think really suggesting how we need to talk about education on historical trauma with medical school as well as other health professional schools.
I
Thank you,
think
Mika.
Dr. Johnson calls that out in his comment. As well, I think that's a very important point.
Yeah, the impact of weathering we're seeing in maternal outcomes as well. So even thinking about generationally, the impact of that is critical. We're seeing low birth weight as a result and the like. So I think these are the conversations that we need to start having.